Let me see. What time do I have? Whoa, I gotta speak fast. Okay. So, oral cancer is a subtype of head and neck cancer. There's three general categories. I know you know this. We'll just go over quickly. There's primary oral cancer, for instance, tongue cancer. There's cancer that is spread from an adjacent anatomical site, such as cancer of the maxillary sinus or skin cancer, either which can grow into the mouth. And then there's metastatic cancer, cancer that spreads from a distant site, for instance, breast cancer or lung cancer. Primary oral cancer can arise from any of the tissues in the oral cavity. You know this already. The most common is squamous cell carcinoma arising from the epithelium. 90% of cancers are squamous cell carcinoma. Obviously, this is a large tongue cancer, although take it from me, these lesions can be missed. The patient goes in to the doctor says, say ah, he looks back at the tonsils, he misses this. Second most common oral cancer, primary oral cancer, is minor salivary gland cancer. This is primarily in the palate, although it can be in the floor of mouth or labial or buccal mucosa. And then less frequency, there's lymphoma, primarily in the neck, although it can be elsewhere in the jaws or oral cavity. Melanoma, sarcoma, this is a Kaposi sarcoma in an HIV positive patient. And then cancers originating nearby anatomical site, nasal cavity, maxillary sinus, facial skin, and the major salivary glands, such as the parotid or the sublingual gland, submandibular gland. A number of tumors metastasize to bone. The most common is breast cancer, followed by lung, colorectal, and kidney cancer. With less frequency, prostate, thyroid, stomach, melanoma, and testis. This is a slide I showed you before. This is a patient of mine with lung cancer. So you see this typical lesion, which is not well demarcated, kind of fuzzy outlines. In addition, the patient may have pain, and a patient like this with a lesion over the inferior alveolar nerve will undoubtedly have numbness of the third division. The other thing to look for in a case like this is that this radiolucency is not periapical. It's away from the roots of the teeth. So we immediately think that this is non-odontogenic. Treatment options in oral cancer are several. Surgery is the one that, of course, I'm most interested in as a surgeon. And surgery is nice because we physically remove the cancer, leaving adjacent normal areas without treatment. We can send it to the pathologist so we know that we got it all, and we know if it may have spread. It's quick treatment. It only takes hours, and there's no toxicity. We'll get into toxicity in a minute. However, especially in the mouth, face, head, and neck, there can be both functional and cosmetic morbidity. There are anesthetic and surgical risks to people who are old or infirm because of intercurrent medical problems. And if we leave microscopic cancer at our surgical margins, there will be recurrence of the tumor. Radiation therapy is another therapy frequently given to patients with oral cancer. Radiation therapy treats both the cancer and the adjacent areas around the cancer. So if there's been microscopic spread beyond the obvious cancer, it's being treated. It preserves appearance and function because nothing is removed from the patient, and it's well tolerated by patients who are old or infirm. And there's no hospitalization for radiation therapy except for radiation implants, which I'll mention in a minute. However, it's lengthy treatment. It takes a number of weeks. There's no pathology, so we can't send a specimen to the pathologist. We don't know if we got it all. And there can be both acute and chronic toxicities. So early on, there are skin and mucosal reactions, almost like getting a sunburn. Later on, we can have xerostomia, we can have alteration of the taste buds, we can have trismus, radiation caries, and radiation caries can lead to osteoradionecrosis. Finally, there's a phenomenon called secondary carcinogenesis. So people who have been radiated for one cancer can go ahead and get a second cancer later on. This is something that is commonly seen after radiation for certain types of nasopharyngeal cancer. That's the cancer, in fact, that I couldn't remember when I was talking about Epstein-Barr virus about an hour ago. Nasopharyngeal cancer is frequently positive for antigens for Epstein-Barr virus. And when we radiate the back of the throat and nasal cavity for Epstein-Barr virus, we have to pass by the tongue, and there's a moderately high incidence of late tongue cancer in these patients. Very interesting. Now, there's several types of radiation therapy. I'm going to zip through this because I've talked too long already. There's definitive radiation therapy, which is radiation therapy alone as treatment for the cancer. There's chemoradiation, in which we give both chemotherapy and radiation therapy. I'll mention this again. There's preoperative radiation therapy, in which we shrink a large or rapidly growing tumor prior to surgery, making the surgery easier. And then there's postoperative radiation therapy, in which we give surgery, then we find either that we have positive margins after the pathologist looks at our specimen, or that we have a tumor that's very aggressive and has a high risk of recurrence, so that we radiate that tumor secondarily. Quickly, we give radiation therapy with a very sophisticated X-ray machine that gives a precise beam of radiation. Our typical radiation therapy is given with a linear field. So here we're treating tumor of the tonsil area, and we give a linear field from both sides. Go back to treat this area. However, the linear field treats many normal structures in the line of treatment. We give it from both sides to reduce the amount coming in on each side, but we still give a lot of radiation to normal structures, specifically the posterior mandible, the teeth, the parotid glands, and the spinal cord. We want to avoid that if we can, so we use IMRT, intensity modulated radiation therapy, where we use computer control to give us a shaped radiation field. And the shape allows us to exclude certain structures. So in this case, you can see our field is here. We're excluding the spinal cord. We're excluding the parotid glands, posterior mandible and teeth and still getting the same radiation of the tonsillar area, which is what we want. Okay, so this is an actual patient of mine with tumor of the left tonsillar area and metastases to the left neck, and we're giving our shaped field, which avoids the spinal cord, avoids much of the mandible, not all of it, we have to get some here, avoids the parotid gland on the left and the neck on the left to give a better result with less risk of osteoradionecrosis and less risk of myelopathy to the cervical spinal nerves. Brachytherapy is implants that I mentioned, and here we surgically implant radioactive implants into the center of the tumor. So here we have a floor of mouth tumor. This patient's obviously asleep in the operating room, and we insert these hollow needles through the neck into the center of the floor of mouth tumor. After this has been done, we drop little radioactive seeds. They're almost like little grains of rice that are radioactive down into the needle, and it boosts the tumor dose to the center of the tumor here without radiating the adjacent normal tissues of the skin, the tongue. So this can give a very nice additional boost to the center of the tumor, but this does require hospitalization for placing of these implants. It's interesting that years ago when I was a resident, we didn't implant these hollow seeds. We actually implanted radium needles, which were, I think, dangerous to us as well as to all the personnel. So now we've replaced that with a much more effective. Molecular therapy is another thing that's going to be hot in the future. And here we're treating tissues which absorb a pharmaceutical that contains some radioactive molecules which zap the tumor but avoid treating normal tissues. It's nowadays used primarily for thyroid cancer, and we put radioactive iodine into the patient. So rather than zapping them, as you see here with external beam radiation therapy, we zap them internally with molecular therapy using radioactive iodine. Various other radiopharmaceuticals are in the process of research now for targeting specific cancers, which will make things a lot easier in the future. Chemotherapy can also be used for oral cancer. Chemotherapy is advantageous because it goes throughout the entire body. So metastatic cancer that we don't even know about can be treated. It preserves appearance and function. However, it doesn't work for every type of cancer. It certainly doesn't work for most oral cancers. It's a lengthy treatment. It can take months or years. There can be severe toxicity, which I'm sure you all know about, nausea, immune suppression, hair loss. And again, there's no pathology. We don't know if we got it all because we're not sending a specimen to the pathologist. Immunotherapy, another treatment of the future. It's being used a little bit now, primarily investigational for oral cancer. But we use genetic testing to find if the tumor cells have a specific DNA profile, and then we can target those cells with various pharmaceuticals that will either activate the immune system to go after those cancer cells, or we can actually put viruses with DNA that activates the immune system to target those cells. So far for head and neck cancer, it's only used for palliation in combination with chemotherapy, although there are some that that are being very successfully for other types of cancer. Some of them I've been amazed are even advertised on TV now to patients directly. So, for treating oral cancer, our mainstays of treatment are surgical resection and radiation therapy. For small oral cancers, each may be used alone. For more advanced cancers, we generally use both. In many cases, we add chemotherapy, although again, chemotherapy itself is not curative except for thyroid cancer. Chemotherapy administered in conjunction with radiation therapy or immunotherapy is cell death for the cancers. Surgery is very important, especially to us surgeons. Several approaches are possible for the mandible. The simplest is the intraoral approach. The advantage is that there's no visible scar. The disadvantage is that it can be technically difficult and that access to the tumor may be very poor. If you're used to working in the oral cavity, then excising a tumor back in an area like this can be something you would want to do, but certainly it can be difficult to be sure you have good visibility of everything. Therefore, sometimes we'll use what's called a lip-splitting incision. This gives us the best access. So what we would do is we would split the lip down the middle, extend the incision under the mandible, and swing the whole thing back to open it up. It does leave us a visible scar. The scar under here is not very visible. We can do things to reduce the visibility of the scar in the lower lip, just right at the midline here and then going around the prominence of the lip over here. It winds up not looking that bad. In some cases, we have to split the mandible and the tongue, as I have in this case, along with the lip, but it provides us much better access to certain tumors. And then when we close it, it's not very bad looking at all. We can also do what's called a visor flap, which is extending a big flap around the neck. The incision has to be long enough that gives us good access to the oral cavity. It could be an ear-to-ear incision like this one, or one that's slightly less, but it also provides us good access by pulling the skin flap up over the mandible to give us wide access to the oral cavity. And here's what closure can look like. We can get good access without things being very visible from the outside. En bloc resection we've discussed already, and we'll get into this partial resection as well. But mandibulotomy is very important. Mandibulotomy is an osteotomy that we create in order to gain access to tumors that are far back in the oral cavity, like tumors of the posterior floor of mouth or tongue-based, or tumors of the tonsil. And we use technology for repair of fractures or for orthodontic surgery in getting there. So there's the tongue base. We've excised it along with part of the mandible, and then we clip things together, pair it. At one time, not that long, instead of doing this, we'd have removed the entire left half of the mandible and discarded it with the cancer, because we didn't know how to repair it, and it was the only way we could get to the cancer. So we removed the cancer with the hemimandible. Surgical approaches to the maxilla include the again, actually, but there's no visible scar, and it's advantageous for certain things like this cancer of the posterior hard palate and the soft palate. You can see the breathing tube running down the patient's throat through the excision. But if we can't get to it intraorally, we have to use an external incision. And the incision that we use is called the Weber-Ferguson incision. It provides us excellent access. There is a visible scar, although it follows normal skin planes, so it's less visible. If it has to extend across the eye, we go in the infraorbital area, along the nose, around the areas in philtrum, across the lip. Winds up not looking very bad. Then we peel the skin flap back, as we did with this lip-splitting incision of the mandible. Provides us excellent access to the maxilla. If the tumor extends up into the eye, we also have good access to the orbit for removing the orbit at the same time, which we have to do in some cases. So here, the tumors are removed. We've had to remove some bone as well, and some of it we can put back. You can see the plates here. Putting the bone back, and the skin's back. And as you can see, it really doesn't wind up looking very bad. I would say if I really criticize myself, there's a little distortion of the canthus of the eye here, coming around here. We can see the incision going across the philtrum, but we're looking for it. It really doesn't look that bad, quite honestly. We can do an en bloc resection in the maxilla, as you can see. But most times we have to move a portion of the maxilla for malignant tumors. This is our typical hemimaxillectomy, where a tumor is not extended into the orbit. We do this at the midline. When I do it, I remove a central incisor. Some people don't and cut up between the teeth, and then they may devitalize the central incisor. But you're removing the tumor and maxilla on the side of the tumor in the case of a number of malignant tumors. As I pointed out, we can remove orbit at the same time. This is called orbital exoneration. If the tumor extends through the roof of the maxillary sinus into the floor of the orbit, the roof of the sinus or floor of the orbit are the same piece of eggshell thin bone, so this does have to be done in some cases. Then we can do a partial maxillectomy for smaller defects that are more posterior, like this. So we could take, since in this case, a canine and excise through there, and it gives the maxillofacial prosthodontist some more teeth to work with in ultimately reconstructing this. I'll get into this. The composite resection, you should understand, means removal of the tumor, the jaw, adjacent tissues that may be involved with tumor, and the regional cervical lymph nodes, or a neck dissection. This is done when we know there are lymph node metastases present, or when they're felt to be highly likely because of the nature of the tumor. Various incisions are used for the neck. I don't have time to get into this, but they use these incisions to give us access for a radical neck dissection. In a radical neck dissection, we remove all of the tissue from cursor, from the trapezius to the midline of the neck, from the clavicle to the lower border of the mandible. Okay? And this includes all 5 levels of lymph nodes in the neck. I won't go into these levels. If we take an axial cut, here's the tissue we're removing. It includes the jugular vein, spares the carotid artery. Most importantly, it includes the 11th nerve, okay? Including the accessory nerve, the 11th nerve leads to loss of motor function of the neck and shoulder. And this is something that patients find very disabling and sometimes painful. So this is something we would like to avoid if possible. And we do that with a modified radical neck dissection. Technically, a modified radical neck dissection refers to anything less than a regular radical neck dissection. But in most cases, it's a radical neck dissection simply leaving behind the spinal accessory nerve, okay? And this prevents neck and shoulder pain and dysfunction for our patients. There's something called a selective neck dissection, and this preserves a lot more. Often we preserve the sternocleidomastoid muscle. We certainly preserve the 11th nerve. Sometimes we leave the jugular vein, still leave the carotid, and often we don't take all 5 levels of cervical nodes. Sometimes we take 2 levels or 4 levels, depending on the location of the cancer. This is beyond the scope of this talk. The key thing you have to understand is, in surgery, we must remove the entire tumor. At the same time, since we're removing the entire tumor and possibly adjacent tissues because of metastases, we must at the same time restore both form and function to the patient. Generally, in 2021, we do this reconstructive surgery at the exact same time as we do the resection. In addition to doing this necessary reconstruction, we also are able to remove huge tumors that we once felt were non-resectable because we were technically unable to do the restoration. There's a number of techniques that we use depending on tumor size and tumor location, and we're going to get into this. Okay, we mentioned we restore form, we restore function. That's ability to support a prosthesis or have dental implants, motion of the TMJ, facial function. So, first is continuity. I've showed you another patient, but after a resection, temporalis muscle pulls the condyle up, and we have to bring it back down to realign it with the remainder of the mandible, put in a bone graft. Once the bone graft heals, we've restored the mandible and have something that can support a prosthesis or dental implants. Patient looks sunken in before surgery. After surgery, has a much better appearance as well as better function. A grafted mandible can support dental implants very nicely. Now, we also have to restore the soft tissue as well as the hard tissue. We have mandibular defects, we have maxillary defects, we have soft tissue defects. With our soft tissue defects, we have both skin that maybe you have to restore, and mucous membrane, which you maybe have to restore. A restoration of the soft tissue gives us a good recipient site for a later bone graft if the jaw has been resected. We need tissue that's bulky, that has a blood supply to support the bone graft, and that does not have a lot of scarring or radiation, which will not support a bone graft. Okay, I mentioned that. Several methods of restoration. We have grafts. Grafts are tissue that is completely removed from its recipient site, and most importantly, from the vascular supply at the recipient site. For a graft to be successful, it has to be revascularized once we put it in. I said recipient site before, but I mean donor site. It has to be revascularized from the recipient site. If it doesn't get a new blood supply, it will not be successful. The other method of restoration is the flap. The flap is very different from the graft. The flap is tissue that's transferred with an intact blood supply. Okay? Very, very different. And then finally, we have implants. We have reconstructive plates, TMJ prostheses, and integrated prostheses, which all have to be used sometimes for reconstruction of these cases. There are three types of bone grafts. The best bone graft, from my standpoint, is the autogenous bone graft. And that's because the patient is the donor for the bone graft, and therefore it's immunocompatible. Furthermore, when you transfer the bone graft, some cells at the periphery of the graft survive transplantation. I'll get into that. The disadvantage, of course, is that there has to be a second operative site. You have to remove the bone from a donor site. There can be complications at that donor site. We have allogeneic bone grafts. This is banked bone that comes from human cadavers. The advantage is that there's only one operative site and that large quantities of cadaver bone are available to us in whatever shape we want and size we want. The disadvantage is that there's an immune response to cadaver bone, and therefore the bone must be treated to reduce its antigenicity. In addition, the bone is completely dead. No living cells are transplanted, and therefore phase 1 osteogenesis, which I'll mention in a minute, is not possible. Finally, there's the xenogeneic bone graft, banked bone that comes from another species. This is the sort of bone that's typically used for dental implants. Again, the advantage is that there's only one operative site and that large quantities of bone in various sizes are available. But the disadvantage is that since it's another species, there's a strong immune response. Again, treatment is required to reduce antigenicity. Again, there's no phase 1 osteogenesis. This immune response can complicate these operations. Various treatments are used to modify antigenicity. They include freeze drying, deproteinizing, denaturization with chemicals, radiation, heating, boiling, freezing. Immunosuppressive drugs are used to stop rejection of organs that are transplanted, also for limb transplants, face transplants, but they are not used to stop rejection of bone grafts. Osteogenesis in bone grafts has two phases. Phase 1 osteogenesis, you should understand, takes place only in autogenous bone grafts. The graft, as I pointed out, dies because it's separated from its blood supply. However, some cells at the surface of the bone graft will survive the transplantation by passive diffusion of nutrients from blood vessels in the recipient site. And these cells participate in osteogenesis. Osteoblasts deposit osteoid on the trabecular surfaces of the dead bone graft. This osteoid is then mineralized. Osteoclasts become engulfed by bone and become osteocytes. Osteoclasts resorb non-viable bone, and new viable bone is created. Phase 2 osteogenesis takes place in autogenous as well as autologous and xenograftic bone grafts. And phase 2 osteogenesis comes from pluripotential cells in the recipient site. These cells are induced to differentiate along the osteogenic line by various factors in the graft matrix, including bone morphogenic protein and vascular endothelial growth factor. Stem cells produce osteoblasts and osteoclasts, which lead to bone formation, and angiogenesis leads to ingrowth of vascular networks within the graft, so the graft becomes living once again. The grafted bone is a framework. It's slowly resorbed, revascularized, replaced by viable new bone. There's several types of solid bone graft. There's the anterior iliac crest bone graft. As you can see here, you can take a graft that's almost the size and shape of a hemimandible. We usually use it for LEST. Here we're reconstructing a defect in the ramus angle of the mandible, and the graft is wired in. Quickly here, above we have immediate post-op, and below, after 6 months, graft is looking very good. We use rib and costal cartilage for a number of bone grafts. It used to be used to reconstruct the entire mandible, but we quickly saw that the rib is much too narrow to do a good job reconstructing the mandible, and now we use it primarily for reconstructing the posterior ramus and condyle of the mandible, and the costal cartilage that we see up here is used to form a new joint surface. It works very nicely for that, as you can see here. There's no calcification of the cartilage, but here is making a new TMJ. Works very, very nicely. We can also use cranium for some cases. It's nice because there's no visible scar after the hair grows back. We can use a round burr to ditch out around the outer table. Come back. What happened? The outer table of the cranium, and take it off. That leaves the inner table behind to stay on top of the brain and protect the brain, so we don't have to reconstruct this. It's most useful, as in this case, for small defects like this one. We can also use the clavicle, and we do a clavicle sharing operation where we take off half of the costal head of the clavicle, leaving the other half to maintain integrity of the the clavicle and hold the shoulder where it should be. The clavicle is nice because it almost looks like a TMJ. In addition, there's articular cartilage and a meniscus, just like the TMJ. So here's what the graft looks like, and here it is put into place, sorry. We also use cancellous bone and marrow grafts. These are not solid bone grafts, these are particulate grafts. We typically take these from the inner table of the iliac crest. You can see I've taken off the top of the crest, leaves me access to the inner table where I can scoop out cancellous bone and marrow. This graft has large numbers of stem cells, and many of these stem cells can differentiate along the osteogenic line and will survive transplantation to participate in phase 1 osteogenesis. So here I am scooping cancellous bone and marrow out of the EM, put it in this container, and then use it for grafting. Typically we do put this in a carrier that has the complex shape of the mandible, unless we're dealing with a very small reconstruction. So here we have the graft particles being placed into a plastic carrier. And here after 6 months, I'm removing the carrier so that the patient can have implants. And you can see that solid bone is now formed in the area where we once had this particulate cancellous bone and marrow. Here's an x-ray of a small reconstruction, particulate nature immediately, and after 6 months, we can get solid. We can also see the fabric pattern of the implant. Now here we have a larger reconstruction. Again, we can see the fabric pattern of the implant, but a very good reconstruction following the complex shape of the mandible with plenty of room for implants. The other type of graft we use is for soft tissue reconstruction, and that is a skin graft, and there's 2 types of, I'm speaking way too slow. Is anybody able to stay another 15 minutes? Okay, well, I'll keep talking, but for those of you, if you've got another class or not, the split thickness skin graft is the epidermis and part of the dermis. We take the tome and split thickness skin grafts shrink as they heal. The full thickness skin graft is the epidermis and dermis, and we take it with a scalpel. We cut it completely off the underlying fat. Full thickness skin grafts shrink very little. Sorry for talking so slowly. The thigh is a common donor site for a split thickness skin graft, and we use this instrument called the dermatome to take it off. And it leaves an area like a skin knee, which heals just the way a skin knee heals. The full thickness skin graft is taken from various areas, but for the head and neck, we like to take it from behind the ear. Therefore, the scar is hidden when we suture it. I'll just show you split thickness skin graft. I used an African American patient for you to see that as it heals, it shrinks. So we see the pigmented skin has shrunk considerably in an intraoral site. Here's an extraoral site. I'm going to have to move quickly. Again, it's shrunk.
Dr. Schwartz, I just
Yes.
want to, the students have let me know that they do have another class. So just so you know.
Okay. Well, if that's the case, I'm going to go quickly, split the full thickness skin graft. Then we have the flap. The flap is tissue transferred from one side to another with an intact blood supply. That's the difference from a graft. Here, the flap, the blood supply is intact. It can be skin, can be mucosa, can also contain other tissues like muscle, fascia, even bone. Quickly, I'm going to go past this. You're not going to be asked about this, but here's a flap, sutured in place. I won't go into the rest, and here it's taken. Axial pattern flap has a special blood supply within it. Nasolabial is an axial flap. I'm going way too quick. Clinical case. Nasolabial flap. The palatal flap is also an axial flap based on the greater palatine artery under here. So here we have the flap with the artery here on the patient's left side with this defect on the right side. Here the flap is sutured over the defect, and here after it's healed, the donor site heals by secondary intention. I'm not going to go over this too much. I'm not going to go over this too much. The musculocutaneous flap is a flap that has a muscle within it that carries the blood supply. And the typical one is the pectoralis major flap, based on a branch of thoracoacromial artery and the pectoralis major muscle, typically brought into the mouth. I'll show you. So here's the chest skin brought into the mouth to reconstruct that defect. And then finally, free flaps are a flap with the dominant vascular supply that's completely separated from its donor site, but then transferred to the recipient site, and the blood vessels are reanastomosed with very fine sutures to reconstruct the blood supply. This allows us to close massive wounds that at one time we felt we could not reconstruct. Here's our arterial reconstruction. The typical one for reconstructing the mandible is the fibula free flap based on the perineal artery. Go through this quickly. Perineal artery sutured to artery and vein in the neck. The fibula, using techniques we know from orthodontic surgery, turned to the shape of the mandible. The skin replaces resected mucosa. Plated to the mandible, we can put implants in this. The radial forearm flap, based on the radial artery, used for soft tissue reconstruction, like the tongue here. Iliac crest free flap for soft tissue and bone. Same with scapular free flap, soft tissue and bone. I'm moving along really quickly. Reconstruction plates are used temporarily, although they may be the only treatment we use for medically compromised or elderly patients. Sometimes prostheses are the best thing for maxillectomy. An obturator is the best thing. The obturator can be put in right after surgery. Hardly looks like the patient had surgery except for the sutures and the skin. Then the maxillofacial prosthodontist makes a definitive one that looks like a partial denture. We can also use a prosthesis for eye reconstruction. If there's an eyelid, we can just put in a typical glass eye. If there's no eyelid, we put in craniofacial implants, which are like dental implants. We would like the implant to be retained, even though it would otherwise fall out. We do the same thing for nasal reconstruction with facial implants and for ear reconstruction. Some massive wounds can be resected and closed with a combination of surgery and these prostheses, and I give my thanks to the maxillofacial prosthodontists who make this sort of thing possible. Sorry to have to speak so quickly at the end, but this is it. I know you guys have another talk right now. If anybody wants to send me a question by email, certainly go ahead and do it.
Dr.
Or
Schwartz.
something really quick right now.
Dr. Schwartz, this
Yes.
is Mustafa. I have a question.
Yes.
So when you talked about the surgical resection of the of cancer, like maxillary mandibular cancer, was there a